Hello, hello to those joining. We're going to give it just a minute or two before we get started to let folks come in the room. You'll notice that all lines are muted just to prevent background noise, but we do hope to hear from you during this session. So feel free to put any introductions in the chat, or if you have questions throughout the session, you're welcome to also utilize the chat box or the Q&A feature. So we will get started in just another moment or two. All right, so just another moment or so. I know that we had many folks planning on utilizing the recording from the session today just because of scheduling concerns, but I know that others are coming from one thing to another, but also want to save as much time as possible for our content today. So we'll go ahead and just kick this off, and others will join us as they are available. So again, hello and welcome to this webinar from the National Center for Equitable Care for Elders. My name is Ariel Mather, and I am the program manager. Today's session is focused on supporting family caregivers to provide oral palliative care for older adults. This session will be presented by Dr. Leonard Brennan, who's the co-director of the Harvard School of Dental Medicine's Geriatric Fellowship Program, and also a lecturer part-time in the Department of Oral Health Policy and Epidemiology, where our center is also housed. And he's practiced general dentistry in Portland, Maine for almost 40 years. I'll let him certainly give more context to his background momentarily. But if you are not familiar with our center, just a little bit of information here. We provide training and technical assistance primarily to health centers across the country, certainly around oral health, but also all aspects of older adult health. We hope that you'll follow us on social media and check out any of our other upcoming training and technical assistance opportunities. Another fantastic resource that those of you from health centers might be already aware of is the Health Center Resource Clearinghouse. Just plugging the COVID-19 resource priority topic page, as it's updated with a ton of great information around vaccine program rollout and emergency management, lots of topics relevant to folks, especially lately. So feel free to check that out. Also for health center staff, this is the last day that the National Training and Technical Assistance Needs Assessment can be filled out. This has been open for, I believe, the past 2 months or so. We would love for any and all health center staff to be able to make their voice and needs known. You'll get the copy of these slides in your email after this session wraps, and you can click on the link. We'd love for you to share your thoughts in this needs assessment. And just a few quick reminders. We're very familiar with Zoom at this point, but lines are muted just to prevent background noise, but we would love to hear your questions or feedback during the session. So feel free to utilize the chat box. As Juliet mentioned in the chat, you can use the drop-down option and click everyone. You can also use the Q&A feature. Like I mentioned, this session is being recorded as we have many folks who are interested in viewing the session after the fact today. We will send you information on how to access that. And when you click out of this session today, a SurveyMonkey link will pop up. It's a brief evaluation survey that we would love to hear your thoughts and feedback on. It'd be fantastic if you could take a few moments to complete that. And with that, I will turn it over to Dr. Brennan.
Thank you, Ariel. Personally, this is a very important topic for me to share with everyone, and welcome. It's probably the #1 call for help that I got from community centers, hospitals, my patients, and other families to assist their patients and to help their palliative care family member. And I think as a healthcare provider, probably the #1 most rewarding service that I provided to patients. But going back to the title just for a second, supporting family caregivers on palliative care, probably one of the number one things that we can do, and I need to mention this, is to support dental services for seniors over the age of 65. Because when we're looking at how do we prepare for palliative care, we prepare for palliative care by not putting out a fire, but preparing what do we do to prevent the fire. So I think that's an important thing to mention at this point. So the learning objectives today are, we're describing the physical and emotional impact, oral health problems for seriously ill older adults. This is one of the number one things I was called in for seniors, on just how they appeared, what they thought of themselves, their inability to communicate. We'll talk about best practice for assisting older patients, and also a way you would collaborate with family members to create action plans. And I think one of the things I would like to do is when you leave today, have action plans to do that will help you serve your palliative care patients and end-of-life patients. Next. When we think of palliative care, it's the symptom management of life-limiting illnesses. And in hospice care, it's end-of-life care, it's management and comfort control. We'll be talking about these later. So Ariel, you can advance, please. I think it's very important to acknowledge it is a very challenging task for caregivers to provide care for palliative patients. It is really challenging, even for the most experienced dentist, to comfortably enter someone's mouth, which is such an intimate and private space, especially when these patients may have discomfort or may be confused. I think it's also important to recognize that it's very challenging to step in to do oral health care when a patient is already on the decline and have missed a lot of the preventive opportunities. So when we think of oral palliative care, it is the management of patients with active, progressive, advanced disease in whom the oral cavity has been compromised by primary disease or by its treatment. And I think there are three critical points I think that we need to at least take a brief look at. One is that critically ill patients are usually totally dependent on others for care, for us. So we need to have and understand our role. Secondly, most seniors that enter palliative care with multiple concerns. So they may develop more concerns in palliative care, but they enter with so many uncontrolled dental problems. Thirdly, I think it's important that effective and evidence-informed guidance for health and care professionals to exist. And there's very little that's in the research today. When the NIH gives us the definition of a palliative care team, it's really made up of different professionals. But when you look at these definitions, what you will notice is that the dentist is often omitted from being part of the team. Not that we're not called on, but we're not called on frequently. Dr. Wiseman, in his book, Palliative Care Dentistry, makes a point of saying the importance of dental care is often overlooked because the dentists are not put on the palliative care team. And I think that's an important point. A second very important point from Special Care Dentistry in 2018 is just the statement that here we are in 2021, and there's still very limited research on what do you do to provide the best care for seniors. So the takeaway from this slide would be, in an action point, is if you're in a care facility or taking care of patients, establish a dentist on your care team. That would be the best way initially to support your patient or your facility. Next, please. I don't know if you're familiar with the Seattle Care pathway, but it's one of very few models that really give you a cookbook and an outline of how you care for patients. It breaks down a patient's dependency, where they are in terms of how dependent they are, and provides an outline for the best way to perform assessment and prevention and management at each stage of dependency. This is an excellent article. It was in 2014. One of the authors of this was Dr. Mark Wolf from he's the dean of the University of Pennsylvania. And their attempt was to have some type of an outline to give to care facilities and dentists in order to manage patients. And it's excellent. I think that this can give you kind of an overview of how you approach not just palliative care, because in palliative care, there's a range in palliative care, how you approach each of those ranges. It really is the nuts and the bolts of how you care for senior adults. So the second activity that I would like, if you have a chance to do, is to review this article. I'll be going through it briefly in a minute, but I think it's an excellent resource for your facilities. Next, please. This gives a brief overview of what's in these articles, in this article. And if you look at the vertical axis, it's from dependent to independent stages. And if you look at the horizontal axis, it follows aging and disease. You can click the first click there for me. Thank you. This first man on the line of aging is a fit individual who really does not need assistance or care of any type. Click again, please. The second individual represents people that are over 65. They may have a chronic disease, but they manage well and they still need very little assistance. Click again, please. The third man represents seniors that have chronic diseases, but these diseases are now affecting their oral health. And it's really important to identify these stages because this is where we want to begin the care, palliative care, before they slide into more complex problems. This individual needs assistance in their care to maintain their oral health. Click, please. So one of the most important parts of where we are entering palliative care is to identify patients, because the time for discussion and strategy of what we do is before there is decline into palliative care. So before we need total assistance or expanded assistance, we need to have a discussion. Click next slide, please. So the time for prevention is also one of the other things that we have to strategize. We want to be, because where today seniors really do not have the ability to access care, our goal is going to be to focus on prevention before you enter palliative care and increase as we go from palliative care into end-of-life care. Next slide, please. The other thing that we want to do is to identify before we enter too far into palliative care, when it is time to redo some of the dentistry that's going to affect and hinder quality of life and end-of-life care and in palliative care. Click again, please. And that could be anywhere down that incline. But the reason it's important to identify it is that if you have fillings that are breaking down or partial that's broken, you have gum disease, or you have certain dental work that is just not holding up, you need to deal with that, or ideally you want to deal with that. So we want to know what we have to do, how do we do it, and how can we afford it? And so that's going to be part of that strategy plan. Next slide, please. Can you go back to that other picture just briefly for me? What this picture represents is, and it's an important point to make, is that seniors as we age look like this before we get into palliative care. So the idea is, the reason we need to strategize is we have to identify what they're coming in with so we can develop some type of strategy. If we can manage some of these patients before they get into palliative care, their life from palliative care to end-of-life care will be much improved. Next slide, please. Now, this is a senior health report card from around 1981. The reason I'm using this initially for a resource is because it shows that even in today's Surgeon General's report, this hasn't changed much. So these are the diseases that you're still going to be seeing in patients as they enter, before they enter palliative care and as they slide into palliative care. All of these diseases you will be seeing in your palliative care patients. What we'll be looking at in a second is the effect of some of these diseases. What's important to realize for the care staff is that dental disease is not a normal part of aging. And I've said that frequently in senior housing and community centers. And second is that the dental disease is preventable and manageable. So it's not normal, and it is manageable, and it is preventable. And that's sort of where we're stepping at. Next slide, please. So the effects of those diseases that we just briefly went through are all of these conditions that we will typically see as major complaints in palliative care and end-of-life patients. Stomatitis, sore mouths, cracked lips, and that can be from medication, chemo, radiation. It can be ulcerations that occur in the mouth and on the tongue, mucositis, that really challenges someone's ability to function well. You will also notice that if there's reduced saliva and there's medications involved, very, very thick mucus. Nausea and vomiting is also a very common complaint as a result of medications, chemo and radiation, candidiasis in the mouth. The challenge of good oral hygiene is always a concern, if not from the patient, but the patient's families. Infections. The number one reason that I get called in many times to see palliative care patients or end-of-life patients, it's not from the discomfort that they're having, but it's the discomfort that the family may have because of bad breath. And denture problems is also an issue, and difficulty swallowing and speaking. I should mention that one of the reasons I use these slides is they're all a face of somebody that I saw. So I want you to meet Sally. I want these are real people, and I think that this is really the people that I saw in their complaints. So you just met Sally. Next slide, please. So what happens with disease and what happens with these common complaints? And this, I think, is really such an important slide for me, because there's a context of body image and social interactions among frail elders that break down. I want you to meet Joe. Joe is a patient of mine who called me in because my grandchildren will not hug me anymore and they avoid visiting me. Now, Joe lives with, and on the lower right-hand side, you'll see yellow broken teeth, cracked lips, multiple infections. And all of these have led to him pulling back into loneliness, depression, embarrassment. He will not smile. But sort of what breaks my heart is the family really avoids the hugs and the kisses. And that was his big concern, no physical contact. Also, friends and family will avoid visits or limit them greatly. So next slide, please. Click, there you go. So research shows that social interactions decrease with poor appearance and odor and muscular function. Research also shows, next please, loneliness and depression double the likeliness of an early death in seniors. Next slide, please. Oral health and disease influence social interactions in all age groups. Next slide, please. There is a widespread belief that attractive teeth are a sign of attractiveness, intelligence. And this is not only from the community that's viewing the seniors, that's how the seniors view themselves and also view their elder community. This next statement, next please, is the one that probably really affects me the most personally and continually motivates me to stay with services that provide palliative end-of-life care. Ultimately, the communication that occurs at the end of life between the terminally ill, the family members, and healthcare are critical for a good death, because it is through only good communication where people's true wishes are heard and understood. Oral health has an important role in this verbal and nonverbal communication. For me, this whole lecture can be summed up. We are called in for a very special role. Next slide, please. So the Seattle care pathway that I had mentioned earlier, this sort of briefly summarizes it. I'm not going to be reading all through this, but if you look at the top gold bar, level of dependency, remember that level of dependency is a range. And what I'm going to be just looking at is the green column that I put in. And we'll be looking at level of dependency across the top and the actions on the left-hand side. So what this actually does for facilities and caregivers is to look at a level of dependency where they are, and then you look at an action plan of what you do for that level of dependency. So in terms of an assessment, you participate with other members of the team. Really important is it's a collaborative effort with social and other services to assess the risks before they fall into disorder. It's really an important piece of this level of dependency. So this assessment, even though I only picked this one on medium, therefore, where I have no dependency, none, or low, it's for every dependency, but it's so much to place. I wanted to give you a flavor of what's in that article. The second action would be, well, okay, medium dependency, he's relying on us for a lot of his oral health. How do we prevent things from getting worse or maintain? So they make statements on how to maintain contact with other members of the healthcare team. It makes you rethink about how you reassess and the need for fluorides. What type of fluoride? Where am I going to put the fluoride? How are we going to afford the fluoride? It also reassesses adverse reactions from medication, and it always gives you a chance to reassess dry mouth issues from medication. So it makes you focus at a specific level of dependency on what they may need dentally. Next, please. The two other areas of action for this level of dependency are really important, and because these two can make a big difference on what happens in the final or end stage, end of care. And one is treatment. What do you do for a patient that's in palliative care but is not very mobile? First thing you need to do is to strategize and come up with some type of a treatment plan to make his dentistry work for them. What can the dental community do conservatively to make this person function well, and something that he can also afford? This use of prosthodontic adjustments, what does that mean? I put this here because I think it's something that's typically overlooked, and it's something that we hate to do as dentists. But if a patient comes in and has two bridges on their back teeth and they can't reach those teeth and they're having a hard time cleaning those teeth, one of the things you need to strategize is if they can't clean under their prosthetic devices, their bridges, is it time to cut those appliances off and let them function with an open space so that they can maintain what they have, and they may not have problems later in that area. Again, you don't do that with everybody, but it's definitely a conversation. And the fourth action is communication. And so when you look at these levels of dependency, it really kind of gives you you stand back and take a good look at a patient, and you think about what we can do for that patient at all levels of dependency. And it's a team approach. Next slide, please. One of the other actions, or what I would recommend if you don't already have this, is any patient that you're caring for to develop some type of an end of life or palliative care toolkit. Now, I'm not going to go through all of these, but on number one, where it says gloves, and I'll cover this a little bit later if we have time, but I want you to be thinking about the patients that you're cleaning, their teeth, may have bacterial infections, fungal infections, or yeast infections. So one of your thoughts when you're cleaning a person's mouth is to protect yourself, and vice versa. You want to be sure that the patient is protected from bacteria that you have. The others are actually pretty self-explanatory. I do want to go to number 4 for a second, mouth props. And because they can be relatively small, mouth props will hold the mouth open So it relaxes the jaw, relaxes the muscles, so you have greater access to get in and do a really thorough job in terms of cleaning teeth. Tie a piece of floss to whatever you're having someone's bite on so they don't aspirate or choke on it. So I've seen that happen. It's a very simple, easy thing to do, but it is a great lifeline. Number 5, lip balm. This I can't stress enough is that the entrance to the mouth, the only way you're going to provide good care is to make sure the door, the opening to the oral cavity is in good shape. So you want to be sure that the lips are moist, they're not cracked. If they become cracked, they're open to infection. So you want to protect the opening of the mouth. Tooth number 8 are these little swabs that we'll see that I see anyway, in rehab and in hospitals to help clean the teeth and put moisture in someone's mouth. Just as an aside, they're terrible at cleaning the oral health of anybody. They're good maybe for dispensing moisture in somebody's mouth, but be aware if you use them, the tops can come off them. These are easy to aspirate. So if you use them once, check them before you put it in someone's mouth, especially if you have a patient who may cough or trigger a spasm. You can lose the tip of that very, very quickly. And the only other, on number 11, it's a way of denture adhesives that can provide comfort in a very conservative, cheap way. So the denture is not moving and allows some aesthetics and it's good patient control. So if we had a kit and had some of these things in it, or if your team got together and looked at what else should we have in it, it would be great to have that ready chair side, because I know time is so limited per patient. Next, please. I don't know if you've seen some of these master oral care cards before, but this is one from Dalhousie. And what I like about it, it's sort of an overview of care. If you look at the top, and this would be great if for any of the members of the team, because it gives you a quick look at what do you do by step. So across the top is the condition of someone's mouth. Let's look at the middle column, natural teeth and dentures. Okay, what do I do with that patient? So if you're in a care setting, it's like a cookbook. Step 1, you remove the dentures, check the mouth for abnormalities, breath, tongue, and teeth. It goes right through exactly what you would do with the teeth. On the top, you may have a denture. What do I do with the denture? Brush the denture, check the denture for problems, soak overnight, rinse denture before putting back in mouth. So it gives you a great overview and a great communication tool for the entire team. In Dalhousie, they had made out a teaspoon of bleach for the denture. You'll notice that it's a cleaning product. It works, but the ADA certainly doesn't recommend using bleach. But what the bleach can do, besides taking wonderful pink denture, it can turn it white. It can also destroy the material so that you can lose teeth off the denture material if you use too much bleach, or it can cause weakness and cracks. Next slide, please. Again, these are just more situations of patients that you would come in. And again, right at the top, it's a middle column again, no natural teeth and no dentures. So here's a patient, comes in without a denture and no teeth. What do I do? And it kind of gives you an idea of, okay, I can handle this. This is a good place for me to start. It also gives, at the bottom middle, the 4 oral health assessment questions for clients. I think these also are very handy because you can make some type of an assessment and also use those as a tool to communicate to other caregivers. Next, please. This is really a kind of a conversation form that I've used for patients for 40 years, something similar, actually much simpler than this, for hundreds and hundreds of patients in palliative care, hospice, assisted living. And really what I wanted to do is to change the goals of how people clean teeth. Because one of the #1 questions that I get in long-term care and assisted care is that the people that are providing assistance feel like they're not doing a good job, that they're not a good caregiver if they can't clean a patient's mouth in entirety. The result is they may neglect cleaning or go by it quickly. What I wanted them to focus on is what they could do well. If you have a patient and the only thing you can do is clean their upper right quadrant, that's all you need to do. And the goal would be is over the course of 4 days or 3 days or 2 days to clean the entire mouth. So when I would call the caregiver, I would have an idea of what was done. And I also have a status of probably what the mouth was looking like. And it was something that they didn't have to spend a lot of time recording. The more that I would place on something, the less I would get back. The questions on the right are often questions that I would ask, and I would just go down and check those. The caregivers often would have the same list. And so my goal was to get a daily status and an overview up to a monthly status. But the goals, I wanted the goals visually to be changed in somebody's mind, that success is not full mouth. Success is whatever you can do it thoroughly. This card then can be passed on to whoever picks up from there. If another family member comes in on Tuesday, or if a different CNA comes in on a Tuesday or a Wednesday, they can look at the card and they can say, okay, a lot of success upper right, where do we move from here? And so basic communication, thinking differently, very effective. At least it was very effective for the patients that I was involved with. Next slide, please. So what would we like what would I like in a dental toolkit? I would love to see providers utilize sodium diamine fluoride, and we'll go to that in 1 second. I think we're all maybe more familiar with different rinses for pain, to desensitize teeth, for dry mouth, for anti-plaque infections, and a number of other types of rinses. So they're very effective, and that should be part of our toolkit. If not the product, certainly the information to get what we need. Same with fluorides. There's a place for multiple fluorides, different types of fluorides. And again, when we're developing a strategy, we want to find out and discuss with the team when and where we would use these. Number 5, custom stock trays as part of the fluoride, how we would use it. But I want to go to 6, the soft denture material, I think really can give quality of life very quickly to a lot of patients. So if, as we age, the bone shrinks, and so this precise fitting denture does not fit on the bone anymore, and if it moves around, it can tear up tissue. So the ability to communicate, to eat, the appearance and self-esteem can be destroyed almost immediately. This material can be placed in someone's denture, fitted gently in somebody's mouth, and it does restore some quality of life. It is important to realize, and I'll mention this in a minute, that the soft relines have a great place in dentistry, especially towards the end of life situations, but you can get bacteria in them. They have to be cleaned, and many times they have to be refitted. The other tool that I would love to see as part of a dental tool kit would be to have an ultrasonic cleaner nearby. Because when you have a denture or a mouth guard or any types of appliances, it would be great to be able to put them in an ultrasonic and clean them. Don't forget that the tartar in somebody's mouth doesn't always just go to the backs of the teeth or on the teeth themselves. Plaque and calculus and bacteria will go to anything that's in the mouth, and it'd be quite heavy. So this would be another tool I would love to see on a dental toolkit. Next slide, please. The ADA has a new policy statement on the use of sodium diamine fluoride for caries management. And this, I think, is going to be an important tool for us in palliative care and end-of-life care. And I think it's the deal breaker. What it is, it's a topical antimicrobial, so it kills bacteria, and it remineralizes or hardens teeth. That's pretty cool. 90% of patients that this is painted on, this fluoride that's painted on. So if you look at the upper right-hand side, you'll see a picture where the painting sort of this yellowish, brownish material on the teeth that will darken. You will stop the decay 90% of the time with 2 applications over the course of the year. The reason this is so important, you don't have to bring the individual to the dentist. It stops the decay, can desensitize teeth, and I'll talk about this in a minute, but it's something that can be applied relatively easily. Now, on the slide, if you see, it says reasons why this product can be great for our patients, besides killing bacteria, it stops existing cavities, stops it. So if you have a situation like the front teeth that we're looking at on the top, and you debride that lightly, and you paint that in, it will reharden the tooth structure. So it also can be, it's great if you have dry mouth. It can be used as a preventative tool, but really importantly, in that last little point, it's easy to apply. You don't need anesthetic for it as a rule. It can be brushed on, and you can have a situation where teeth are harder, they may not break as often, fewer dental concerns. Next slide, please. And when we're thinking about fluoride, many times what we end up seeing is front teeth, but it can be placed on back teeth by cleaning it out with a little bit of a hand tool and placing it in. It certainly has its place. It can also be used, next slide, please, if teeth are broken off at the gum line and we still have a situation where there's not a lot of pathology in the teeth, you can just paint it over the surface. It will arrest decay, stop decay, desensitize those teeth, and provide function. So if somebody is in end-of-life care, what a wonderful tool to assist that patient in being able to eat. Next slide, please. One of the questions that I may get frequently from caregivers, well, don't they complain about these black teeth? The answer is no, they tend not to. So the reduction in sensitivity and the ability to chew can be an issue. But let's look at one of the other functions of the sodium diamine fluoride. That is, if you have a situation in palliative care and you're not mobile, but we're worried as caregivers that that cavity is going to get worse. But we also know that that particular patient may be mobile in, say, 4 weeks once he recovers from, say, pneumonia or whatever it is. Sodium diamine fluoride can hold that tooth in check, generally, until that person has the ability to travel to get a regular filling in it. So this is it's a non-restorative treatment with the goal, if possible, to restore these teeth. But it is a great tool and a great mechanism. Next slide, please. This I think we're all most familiar with is the reduction of caries with the use of fluoride, and not going through all of what these represent or statistics and percents, but just overall fluoride product from a fluoridated water to the use of toothpaste and varnishes that we may paint on the tooth, or the sodium diamine fluoride, they all have a role in reducing decay and sensitivity and allow the teeth to strengthen and provide function. So one of the things that we really want to do with palliative and end-of-life care is how do we keep these patients from progressing in disease? And all of these products work really, really well. Next slide, please. So the proper use of fluoride in palliative care patients can stop cavities from occurring, can arrest them. It can protect the teeth not only from acids from sugar, but a lot of our palliative care patients undergoing chemo or radiation may vomit, which is very acidic. And the acidity can destroy the tooth structure very, very quickly. So fluoride has a really important role for our patients. It can strengthen teeth, as I had mentioned, and also desensitize teeth. Very important role. Next slide, please. When we look at brushing, I'm not going to go through the mechanisms of it. This is going to be in the slide pack, and you can read down through it. But I think one of the first point, establish the oral hygiene goals, is hugely important. So when we're going to brush a client's teeth, our family members' tooth structure, what is our goal? That was, I think, the number one failure that I've seen over the 40 years going into facilities, that if you have an unrealistic goal, you have a discouraged caregiver and they feel bad. They're in healthcare to provide a service. If you feel that you're not providing a reasonable, realistic service, the quality of the brushing decreases. If you have a combative patient and you're lucky to get 3 or 4 teeth done on the upper right, they would call me discouraged and say, all I could do is these 3 or 4 teeth. What do I do? This person's not going to do well. He's going to get cavities and it's my fault. Instead of, congratulations, you got those 3 or 4 teeth. Tomorrow we're going to do another 3 or 4. And I will have them remember the goals of what they're doing. When you leave a dental office after a cleaning, there's an average of 100,000 good bacteria and some bad bacteria in the mouth. So that's after a cleaning. What happens in long-term care and palliative care patients, that these bacteria multiply very, very, very fast. So instead of having 100,000, 200,000, we have billions to trillions of bad bacteria that can produce acid and disease to the teeth and to the gums. So it's important to point out their accomplishment, but really to establish what their goals are. The only other thing that I want to talk about on the slide really briefly is just remember that if your patient has a yeast infection or any type of an infection, remember that you do not only treat the mouth, but you treat any appliance that goes in the mouth, the dentures, the partials, the mouth guards, and toothbrushes, floss aids, and proxy brushes. So if you don't, you can reestablish a colony of bacteria or yeast just by cross-contamination. On flossing, it's really difficult. I think this is maybe one of the most difficult exercises to do with a palliative care patient. If you have somebody that is compliant, you can do it, or somebody really wants it, that have taken care of themselves. It's a good thing to do, and there are tools for it. We'll talk about those. But one of the tips, if somebody really wants to have their teeth flossed, remember how it's difficult to get your big hands in somebody else's mouth. So you do have floss aids that can help you on this. But if you lay the patient down and you're sitting on the end of the bed or kneeling near the bed, it's easier to floss a patient in that position. So that's just a helpful hint that I found. Next slide, please. There are a lot of different aids that really can make a difference in helping a patient brush their teeth. Now, our goal as caregivers is not to take over every role that our clients have for self-care. It's important for self-esteem and to feel good about yourself and to feel that you're not in a complete state of decay, to be able to do some of your own home care. These aids help. The one on the upper left is just an aid that you can put on the edge around a toothbrush. And what it does, it allows the hand to go through it, but helps stabilize the toothbrush, and it works really, really well. So I made this just for my hand on a toothbrush, because you can adjust it. If somebody has arthritis, it can be accomplished in many different thicknesses. On my hand that's in the middle there with the toothbrush, as simple as taking a toothbrush and putting an elastic over the top, wrapping around my hand and around the bottom, holds that toothbrush in place, and it allows the patient to accomplish a lot of their home care themselves. Simple tips make a difference, do not cost any money. The water pick is great. Again, I think trying to use a water pick in palliative care and end-of-life patients is very difficult. If you use them, just be sure that you use them on a 45-degree angle. Next slide, please. Probably one of the most important parts of preventing disease in palliative patients is this diagram. We talked about the oral health, oral hygiene. You need to remove as many of the bacteria as you can. The more bacteria, better the hygiene, the less disease. So we have some control over that. We also have some control over the type of diet that our clients might have. Think about the form of the diet. If you have really sugary chocolate that sticks to the teeth, that's going to cause a lot more decay than something that, like a soda that rinses by the structure. The other is we have some control when we look at saliva, that we have the ability to have artificial saliva substitutes, and we'll be talking about that in a minute. But when you put these together, we have control of this, putting out the fire before we have a major issue that's occurring. Next issue, please. Probably the number one question that I get going into care facilities is on this slide here. How do I approach a palliative care patient? And I think the first thing that you want to focus on is just remember that that space is intimate, and they don't. And when you enter that space, they can feel like an assault to a patient. Ask permission to enter the mouth. Secondly, remember that many patients who may have very bad teeth may have very bad phobias, and they look at you as a dangerous situation. So you want to keep that in mind. It may not be neglect as much as it is a phobia. Third, patients may have years of neglect, so just proceed slowly. I'm going to go down to the fifth point just for a second, because a limited capacity to communicate can be a major barrier to receiving care. So it's really important to always inform before you perform. They have lived a life and they're familiar with what's happening to them, and they need to be part of that conversation. We talked about 6 already. Let the patient do as much as they can so they maintain as much dignity as possible. Next slide, please. All of the initial, when we looked at the diseases and the symptoms of the diseases, and we looked at, if you look at common causes, trauma, sharp teeth, dry mouth, may have very similar symptoms to deal with. So when we're dealing with a painful mouth, what our first approach is going to be is to see if we can identify the reason and take care of that. And so that's going to be the number one. If it's a sharp tooth and it's cutting the gum, we want to take care of that. But the treatments in terms of getting the pain under control can be very similar to all of the conditions that we talked about. Plaque control, sodium diamine fluoride, different types of mouth rinses that can make a big difference in terms of relieving pain. If we have time, I'll go back and talk about the magic mouthwash that typically is given to patients in cancer, radiation, and therapy. But it works in a number of patients, and it's a cocktail of multiple different materials that can make a difference in some patients. It does not work in all patients. In some patients, it can make them worse. Next slide, please. So one of the most common ulcers that we will see in end-of-life care can be an aphthous ulcer, because what triggers them is stress or dysfunction, immune dysfunction. So it is something that we will see. Again, try to identify the cause. What are the predisposing factors? Is it stress? Are they allergic to the preservative in the toothpaste? Is it smoking? And then if we can control that, then we're going back to how do we deal with the pain management, which is going to be very similar from one condition to the next. So always see if you can identify the problem and then move to pain management. Next slide, please. I think we sort of cover this in a couple of different ways, but the management of bad breath really is how do you remove the bacteria and control the bacterial colonies. And we talked about the diet and the fluoride and the sodium diamine fluoride, how to brush well. But if you don't, and this type of a condition is in a patient's mouth, we're going back to that patient that I showed you, Joe, that would say, how come my family doesn't hug and give me a kiss? And you can see why here. Next slide, please. With candidiasis, again, it's one of the most common side effects of smoking and dry mouth and chemotherapy. We want to, again, try to identify it so we can have team members that can intervene to take care of the candidiasis. Once that is under control, then we can deal with what's common to all the other types of common complaints. The swelling, the soreness, the lack of saliva in somebody's mouth, the decay, unable to eat, very common, and that's where the diseases intersect. just keep in mind that 90% of patients with cancer therapy may easily be involved in this. And in the picture on the upper left-hand side, most of the angular colitis that's in the corner of someone's mouth, 90+% have some type of yeast infection involved. Next slide, please. This is going to be on a handout that's attached. So I am going to go by the slide. Next slide, please. And just point out the other common complaints that I'm called in for: trauma. The slide A is just trauma under a denture. The other is trauma under partials. It can be a cracked tooth, or it can be a partial that can be stuck in some side of someone's cheek. Next slide, please. Next slide, please. We talked about refitting a denture. So this is a visual on how the bone shrinks. What it can cause is next. How you can refit a denture with a very soft material that can be done bedside, chairside, and fitted, and that will give you function and cosmetic. Next slide, please. This is a very important slide, and then we're going to slide towards by a few slides. But when you think of what you have control over for quality of life, dry mouth is something that we do have the ability to assist a patient with. Dry mouth will cause a lot of these symptoms on left. Swallowing, the inability to speak well, burning sensations, etc. But we have certain actions that we can do to make that life better. Avoid caffeine, citrus fruits, alcohol products, tobacco. So we can avoid substances. We can also protect the teeth from sugar and rinses that we talked about. We can also, as an action, replace lost secretors. So if we don't have saliva substitutes and milks, and so all of these can replace what's lost. We can also take an old gland that's not producing well and re-stimulate it to produce saliva. Next slide, please. I have already talked about the importance of the entryway into someone's mouth. It's hard to provide oral care if you have the entryway that looks like this. So maintain the lips, and there's lots of ways to do it. This is also in the handout that I have, but it can make a world of difference for patient care. Next slide, please. Mucositis is really one of the most difficult oral complaints in end-of-life care because it is so painful. One of the keys in dealing with mucositis, one of the keys is planned strategy. So patients have an idea of what they're facing, and to be sure you're really involved in that preventive strategy before you get into this type of a situation. The number one relief that I get from patients is not from a product, but if they call me or if I go over and say, this is going to be here for a bit, you're going to be okay. And then we have some products that may help you. And in some of those, again, if you look at again, a painful mouth, it's very similar to some of the other painful mouths that we talked about. Also in the handout is an idea of what's included in a magic mouthwash. Next slide, please. Next slide, please. When we talked about their viral infections, just remember, protect yourself, protect the patient, think gloves. Next slide, please. We talked about this also, following chemo and radiation. It's very easy for patients to vomit, and it's a situation that can destroy tooth structure. We have already talked about ways of preventing disease. We want to utilize the skills that we just talked about to protect these teeth. Next slide, please. And next slide, please. So if we put everything together that we just talked about, think of things that you can do immediately that can make a difference. Develop an action plan that puts an oral healthcare provider on your palliative team. I would recommend to review that article, the Seattle Care Pathway, because it gives you a good overview of treatment. Third, I think it's very important to plan and strategize before you have someone go into palliative care. That's the best strategy for support. Develop a toolkit for the dentist, develop a toolkit for the provider, and the blocks underneath this really emphasize communication, communication, communication. Thank you.
All right.
Questions?
Wonderful. Thank you, Dr. Brennan. Yeah, we have a few minutes for any questions. We can give it a moment for folks to type anything. Certainly, you can use the Q&A or the chat. I know that there were several slides that Dr. Brennan passed through just for now, but to reemphasize that the slides will be sent as a PDF to participants. And we do have an additional handout with some of those key points that Dr. Brennan shared as an easy take home that will be emailed to folks as well right after this session wraps up. So we'll give it another moment for any.
What I can do is,
Yeah.
while I'm waiting,
Yeah.
the magic mouthwash is something that if you're in end of care, or if you've had chemotherapy or very painful mouth, it's one of the elixirs that we prescribe for patients, physicians prescribe for patients. And what it is, it's a concoction of multiple different ingredients that can help a patient. So when we say magic mouthwash, it's more than one. There's one super magic, there's Duke's concoction, there's the super pink lady. And so what's important is what's in these mouth rinses are everything to manage in that pain segment. There's something for allergic reactions or inflammation of Benadryl. There can be also something for Candidiasis, yeast infection, bacterial infections. Many times lidocaine is involved in to numb the mouth up. There's also a steroid that can reduce the swelling. So a magic mouthwash is a concoction of one or three of these. The idea is to assess a patient and then to put into that magic elixir what people need the most.
Wonderful. Thank you so much, Dr. Brennan. I know we've had a couple of questions about the recording, and rest assured, we will be sharing that as soon as it's available. We do put all of our webinar recordings up on YouTube, so it takes us just a day or two to get that set, and then usually a week or two to get that closed captioned. But we will have that as a resource available for everyone, including those who just registered but weren't able to attend today. Just as we have just a couple of moments left in the hour, I want to thank everyone for their time. As I mentioned, when you close out of Zoom, you will be prompted to fill out a SurveyMonkey evaluation. We would love your feedback on what you thought about today's session, as well as any other ideas you have about future training and technical assistance topics. So we would love to hear from you in that way. I see the question of the name of our YouTube channel. Yeah, so it's under our center's name, so National Center for Equitable Care for Elders. I think one of our team members can put a quick link there, but also perhaps link you to our website that has a list of all of our webinars and can also get you to our YouTube page. So we would love to stay connected with you. Feel free to keep in touch. You will receive an email from us shortly with lots of resources. We thank Dr. Brennan so much for his time and expertise. If you end up having questions for him that come to mind after the fact, feel free to respond to the email that we send shortly, and we can pass those questions along to him. So again, thank you so much, everyone, for attending today. And for those who are viewing the recording, feel free to be in touch with us if you'd like to share your thoughts, and have a wonderful rest of your day. Yes, and thank you so much for those links, Juliet. Take care, everyone. Thank you.
Thanks, Juliet. Thanks, Ariel.